Welcome to our fourth and final day of this incredible MAMES 2020 virtual conference and exhibit hall event. We may be in all corners of the country, but are and connecting that space between us. So let's kick off our first session of the day by grabbing a cup of coffee and sitting down with the DME MAC to get the latest updates on Medicare. This morning, we will join staff from DME MAC jurisdictions A, B, C, and D to get the latest information on all the hot topics surrounding Medicare reimbursement. You will also gather more information regarding the COVID-19 public health emergency waivers and flexibilities, policy updates, audits, and more. You will be able to join in a back and forth discussion in this event at the end. Our speakers for this morning's Coffee Break with Medicare sessions are Cindy White, Provider Outreach and Education Consultant with Noridian Healthcare Solutions, LLC, for the DME MAC jurisdiction A and D. We will also hear from Judith Roan, Provider Relations Senior Analyst with CGS for the DME MAC jurisdiction B and C. So without further ado, I hand it to you. Cindy and Judy, take it away.
Hello, everyone, and welcome to the Medicare Fee-for-Service Update Session presented in collaboration by CGS and Noridian Healthcare Solutions. My name is Cindy White. Many of you know me, and I will also be joined for the live Q&A by my colleague at CGS, Judith Roan. As you know, our standard disclaimer for all information provided today is that it is current at the time we're providing it, and in this case, in the time it was prepared. Change can occur frequently, so we do strongly encourage everyone to use the source documents referenced today, as well as both the CGS and Noridian websites, in addition to the CMS website. So our agenda is for the prepared presentation is fairly short. We want to share a little bit of what's new with the fee-for-service Medicare program, review the COVID-19 public health emergency waivers and flexibilities. We do have some resources, of course, and then we'll move on to your questions. We did receive some pre-submitted questions, as well as we'll take live questions throughout that time frame, and that's what the majority of time will be spent on today. So let's get right to what's new and what we want to share. We do want to begin with the insulin infusion pumps with integrated continuous glucose sensing capabilities and the related accessories and supplies. As many of you who provide this service will already know, that effective for claims with dates of service on or after September 15th of 2020, which has already passed, the codes that are listed on the slide became invalid for billing to Medicare, that E0787 as well as the A4226. Both of these codes were added effective January 1 of 2020. However, CMS did become aware that there were some complexities associated with the two codes, and they did hold a public meeting. Following that public meeting, they allowed suppliers to comment, and after careful review of those comments submitted and the issues surrounding the use of these codes, CMS did make the final determination that the two codes, the E0786 and the A4226, I'm sorry, the E04787 and the A4226 would become invalid for Medicare submission. As a result, what they did was create, we already had the other two existing codes. So effective on September 15th again, you must now bill the E0784 and the K0554 in place of the E0787. So that new code E0787, which became invalid, is now replaced by E0784 and K0554. You have to bill both codes with the RR modifier when they're used to describe that E0787 product. They are still valid in other cases, And the one important thing to remember is while the K0554 is an IRP item, when it's billed in this instance, it is required to be billed as a rental. So then the payment for the K0554, which is the continuous glucose monitor, that CGM, is only available if the beneficiary doesn't already own the CGM receiver or if the 5-year reasonable useful lifetime has passed. We also want to note that any combination of paid rental claims for the E0787 and the E0784 for the insulin pump used on a continuous basis by the same beneficiary for any date of service will count toward that 13-month rental. Federal regulation does require that the supplier of the insulin pump in rental month 1 continues to be the supplier who provides the pump for the remainder of the 13-month capped rental period, or until medical necessity for the pump ends, whichever is sooner. And additionally, for those suppliers who previously coded A4226, suppliers must use the separate supply codes for the insulin pump and the CGM supplies, and those are A4224, A4225, and the K0533. For reference purposes, there is a joint DME MAC article that was published by the medical directors back in July. That was on the 20th, and you can find it in each jurisdictional website or on each jurisdictional website. Pardon me. I love these more when they're in person. We also want to be sure to note that the new ABN, the Advanced Beneficiary Notice of Non-Coverage, has been released and is available on the CMS website. The deadline was September to begin using the new ABN form. However, CMS, due to the public health emergency, has extended that mandatory usage. So it will become mandatory January 1, 2021, and remain effective through June 30th of 2023. You are welcome to use the new ABN now. It is simply not a mandatory requirement until the 1st of 2021. In other news, we've also received inquiries on the new CMN as well as the new DISC forms. And please note that these two have been updated and now dates where they are effective through February 2nd of 2024. The next topic under what's new is not all that new. We've been sharing it for a while now, but we do want to also make sure that everyone is aware that under the condition of payment prior authorization, we all know that earlier in the year, due to the COVID-19 public health emergency, this particular prior authorization program became voluntary. It has now resumed as mandatory. So beginning on August 3rd, all power mobility devices as well as pressure reducing support surfaces resumed their mandatory requirement for the prior authorization. And then on September 1st, lower limb prosthetics were added in the demonstration states, which are California, Michigan, Pennsylvania, and Texas. Following that, lower limb prosthetics will be required for prior authorization nationwide, and that will begin on December 1st. You can see the codes for LLP listed on the slide, and if you have questions, both the Noridian and the CGS websites have access to the information on our medical reviews tabs under pre-claim review or prior authorization, depending upon the jurisdiction that you will be billing. Excuse me, I'm actually going to take a drink of beverage because I definitely have a frog in my throat. I would do the same thing in person, so I guess that's okay. So let's talk about the medical review resumption now. Another change under the waivers and flexibilities is that we did pause the targeted probe and educate project under CMS's directive. So no letters went out, and we didn't take any additional action even to those cases that were in process. What has occurred now is that CMS has instructed the DME MACs to resume medical review. However, we're not resuming the TPE program. That will come sometime later. What we're doing today is post-payment reviews. And you can see both the codes that CGS is reviewing as well as the codes Noridian are reviewing on our respective websites. Do note that the only dates of service selected will be those prior to March 1, and this process did begin on August 17th, so some of you may already have received letters. But our websites do indicate the codes that will be under review, as well as will ultimately have results of those reviews once there's enough data to report. Because we know that so much depends on the practitioner's records, and we always talk about this, we do want to remind everybody that we have clinicians or physicians corners on our respective website. You see the clinicians corners for jurisdictions A and D, as well as the physicians corners for jurisdictions B and C on your slide, and the links to locate those. And we certainly hope that the medical director letters and the checklists and the information that we have on those slides or on those websites will assist you in providing information to the practitioner. Please feel free to provide all of us feedback if you have something that you would like to see on our practitioner information websites. Another change that's looming on the horizon involves the billing of the G codes for home infusion transitional services. Those codes were previously billable to the DME MACs and will no longer be billable to the DME MACs effective January 1, 2021. We are anticipating holding webinars that will provide explanation of what the transition will be, as well as provider enrollment for Part B if you continue to provide those services. Again, something that happened a little while ago, back in July, we did want to share a reminder that the KU modifier is needed to receive the unadjusted fee schedule amount for some of those accessories provided in conjunction with manual wheelchairs. Because it began in July but was effective back to January 1, suppliers were instructed to submit a reopening request for any claims that had been submitted without the KU modifier between January 1 and June 30th. So if you still have claims that require reopening to receive that unadjusted amount, then you do need to make sure that you file the reopening. And again, contact your respective jurisdiction if you have additional questions. Website links are listed here as well. And now for the CARES Act adjustments. At press time, the automated adjustments that were to be completed by the DME MACs had not been finalized due to some systems issues. And we were certainly hoping, and I'm still crossing my fingers as this is recorded today, that we will be able to tell you that they are complete once we meet with you for our actual presentation. We believe that those system issues have been resolved, and I do know that all 4 jurisdictions were in the process of making the adjustments. So I do hope that when we get to the live Q&A, we'll be able to report that those are done. One final area under what's new that I particularly thought might be of interest was the fact that CMS is reopening the oxygen LCD for the review of use of oxygen to treat cluster headaches. But they also announced in that reopening that due to lessons learned during the COVID-19 PHE, that they are going to review the entire oxygen LCD. Now, the comment period ended on September 16th, so that's not available, but it certainly is a development that any oxygen supplier is going to want to follow. So do stay tuned for information to come on what CMS finds and what they learned from that comment period. All right, so that does wrap up all of our new information up to the time of this recording. We'll take a few minutes to go through the COVID-19 public health emergency, waivers and flexibilities, and then we'll move into some resources and get on with the live question. So do keep in mind that there are multiple scenarios where the CR modifier and the COVID-19 narrative are to be used. Anytime you use the CR modifier, you must use the COVID-19 narrative. CMS published that MedLearn Matters article SE 211 back in June, and it gives significant instruction on the use of both the CR and the DR modifiers, but we do want to clarify that only the CR is applicable to DMEPOS items. The CR modifier is not required if there's the claim that you're filing has no impact by the public health emergency. However, if you do append a CR modifier, we won't deny if it's appended in error. If you have previously submitted claims that did not have the CR modifier, you don't need to do anything about it unless claims payment was affected. If that were the case, then you would want to resubmit with the CR modifier and the COVID-19 narrative. Uh-oh, my slides don't want to move. Let's see what we can do here. Ah, there we go. So the first place that the CR was offered was for lost, stolen, or irreparably damaged equipment, which is pretty typical of any kind of an emergency scenario. We would not expect to see the COVID-19 cause lost, stolen, or irreparably damaged equipment in very many cases. Certainly it's possible, but most equipment can be appropriately cleaned and continue to be utilized. But if there is a case where the equipment is lost, stolen, or irreparably damaged as a direct result of the PHE, then you would want to use the CR modifier and append the COVID-19 narrative. Additionally, CMS originally issued direction that prescriptions up to the quantity that were originally dispensed in the cases where the dispensed medication was lost or became unusable as a result of the PHE could be replaced in their entirety. The other flexibility regarding medication allows all medication to be dispensed for a 90-day supply in addition to even if they only generally allowed a 30-day supply. Probably one of the biggest issues has been the flexibility for the non-enforcement of the clinical coverage requirements, the clinical indication of coverage for certain policies. And those would include the respiratory policies, oxygen, infusion pumps, and continuous glucose monitors. For those, the clinical criteria are not being enforced by the DME MACs. However, we do want to emphasize that when those particular services are provided, there must be a medical need for those services. So just because we're not enforcing the regular clinical indications that exist in the NCD and the LCD, there does need to be documentation of a medical need for the use of any of those services. And we'll certainly take additional questions if that needs additional clarification. CMS also indicated a flexibility in the interim final rule that stated that to the extent that any policy required a face-to-face evaluation, that could be done via telehealth during the COVID-19 public health emergency. So telehealth is definitely in use and being utilized for all of those face-to-face or in-person encounters that would normally be expected to occur based on the directions from the national coverage determinations and the local coverage determinations. And finally, the signature on proof of delivery has been waived. We do encourage suppliers to indicate on your proof of delivery why the beneficiary was unable to sign. We know that beneficiaries are reluctant to get close enough to sign as a result of the social distancing requirements, as well as we know suppliers want to protect their employees. So CMS acknowledged that and did indicate that a signature on proof of delivery would not be required. We do not have it addressed in this presentation, but there are directives for non-signed ABNs as well. And the other thing that we do want to emphasize is that at the time of this recording, the AOB or beneficiary authorization does require a signature by the beneficiary in order to build a Medicare program. We are currently investigating that directive with CMS, but we do want to make sure that we get that information to all of the supplier community. And then as far as resources go, these are pretty much the standards that you see from us in general. For jurisdiction A, of course, Noridian Healthcare Solutions is the DME MAC there. We have website, IVR, information, as well as the link to our policy articles. And we encourage the use of our portal. We would like to see more work done in the portal, and for those of you who are utilizing, I'm sure you've found advantages, so continue to do so. If some of you out there are not utilizing the portal, please be sure to investigate it. Moving on to jurisdiction B at CGS, please note that they also have a portal called My CGS. And again, I would emphasize that if you are currently using it, I'm sure you can attest to the advantages. If you are not using the portal and you're billing jurisdiction B, please do consider getting on that portal because you have a plethora of information at your fingertips. You'll also see their website here, as well as the IVR, their customer service number, and a link to LCDs and policy articles. Because this presentation is available to all jurisdictions, you'll see those same resources from CGS for jurisdiction C, which I won't read to you, and you'll see the resources from jurisdiction D at Noridian as well, mirror those of jurisdiction A. So we do a lot of collaborative work, and we are grateful for that opportunity to join all of you here today. And with that, I thank you for your attention to the recording portion of our presentation. And we'll move on now to the live questions, and we look forward to chatting with you. Again, this is Cindy White, and Judith Roan will be joining me. Thank you.
Wonderful, ladies. Excellent job. I know there's lots of valuable information, and we do have a lot of great questions today. So I will pass it over to you, Judy, and if Cindy, we can turn on your screen and see your lovely face. Here we are.
Hello, everyone. Judy, are you there to help coordinate our questions as I come to you live from my niece's bedroom?
I am also live. Unfortunately, I am not on camera, but thank you so much, Cindy. I had been asked to answer or review a few of the questions that we had received through the Q&A panel. So one of the questions is, was the prior authorization requirement suspended for all power mobility, including the K0861, until July of this year due to COVID-19? And prior authorization was not technically suspended, but it was voluntary until August 3rd of this year. And so during the PHE, it was voluntary. So you could still submit your prior authorization requests, but it was voluntary until August 3rd. I received a follow-up stating that no PAR was done. Sorry, the questions are moving. That no PAR was done, but they denied the claim for K0861 for data service 4/6/20. What may have happened is that claim may not have been submitted with the CR modifier and COVID narrative. Unfortunately, I cannot see a specific claim, so you would want to check with the jurisdiction that actually processed your claim. Do you know how they will be handling oxygen CMNs that may have been handled due to the COVID? I'm sorry, the questions keep bouncing on me. I'm so sorry. As at 11:35 with no CMN. You would continue to follow the previous instruction that is available on, I know, the CGS website on our COVID page with the CR modifier, the narrative, and any other applicable modifiers. An additional question is, what is the difference between ADMC and PAR? So ADMC is a voluntary program, very limited wheelchair codes as of right now. And PAR, or Condition of Payment Prior Authorization, is a required program. We have received different time frames in which the DME MACs must process those prior authorization or ADMC requests, and that's why your ADMC request may take a little bit longer than your prior authorization condition of payment requests. And Cindy, is the ADMC available through the Noridian Medicare portal, the status?
Sure. At this time, I do not believe it is, but I would recommend it to anyone who would like to see that to make sure that you complete the portal survey, and that will give us the opportunity to make sure we put that in our list of enhancements.
Excellent. Thank you so much, Cindy. Then we received a question regarding the COVID waivers and if they will continue as long as we're in the pandemic, the PHE. And we have not received an end date as of yet, so those waivers will continue until we receive notification that they will be discontinued. So they are currently ongoing. If and when they are ended, we will absolutely be sending information to the entire supplier community. Another is elaborating on the signature requirements for proof of delivery during the COVID pandemic. And Cindy did talk a bit about proof of delivery documentation and the waiver or the non-enforcement of signatures for proof of delivery. Also, for advanced beneficiary notices of non-coverage, there is some flexibility for your ABNs as well. The only information we don't have on beneficiary signatures is regarding your assignment of benefits. We are currently working with CMS to obtain clarification and additional guidance on the assignment of benefits. Let's see what else we have. Deanne had sent a question. She sent her reopening for a KU modifier for a K5 and an E1161 and did not receive any adjustments. Unfortunately, I am unable to review any specific claims. Cindy and I are also unavailable to review any claims, but I would definitely check either the portal of the jurisdiction for which you submitted that request, or you can absolutely check status through the IVRs. Let's see what else we have. Our handouts available. There should be a button in the webcast hall, and you should be able to download from there. Okay, that looks like all of the questions we had answered. Now, I did want to provide some additional updates from the DME MAC, at least from Jurisdiction B and C. Specifically for Jurisdiction C, on October 1st of this year, Jurisdiction C had won its recompete for the DME MAC Jurisdiction C contract. So CGS is going to continue to be your Jurisdiction Jurisdiction C DME MAC from September 1st of this year through August 31st of 2027. So we will continue to be the DME MAC for Jurisdiction C. We don't expect there to be any transition issues whatsoever. We have created a transition dedicated web page. If you are interested, you can just go to our home page and type in Jurisdiction C transition. And some additional talking points. I believe Cindy had really provided detailed information which was requested for the COVID-19 PHE. And there is information on both of our websites, on Noridian as well as the CGS website, for COVID-specific issues. So I know for jurisdiction B and C, we do have our information sorted by topic. So if you are a jurisdiction B or C supplier, you are welcome to go to the COVID-19 pages. It's right on the left-hand navigation of our website. And you can type in oxygen, CR modifier, you could type in ABN. It will give you all of those available resources for you. One additional topic that I wanted to bring up before I turn it back over to Cindy is we have had a claim issue for jurisdiction B and jurisdiction C. So some claims have processed incorrectly against medically unlikely edits, or MUEs. These claims were in process between 9/23 and 9/24, and you may have received a CO 151 denial in error. We are currently working quickly to resolve these issues. Nothing needs to be done by suppliers at this point in time. So if you believe you've received a CO 151 denial in error, please just hold on. We are updating and correcting those claims as quickly as possible. Okay, Cindy, I'm not sure if you had any jurisdiction A or D specific updates you wanted to provide.
I do. Thank you, Judy. I appreciate that. For A and D both, I promised you in the recorded presentation that we would talk about the CARES Act adjustments, and I can report for jurisdictions A and D, those adjustments have been completed. I would imagine that they are nearing completion at CGS as well. So Judy, did you want to comment on that as well before I move on to any other topic?
For jurisdiction B, the CARES Act adjustments have all been completed. For jurisdiction C, they have been completed. However, some of the claims may have been affected by the CO 151 issue. So please keep that in mind for those CARES Act claims. Thank you, Cindy.
Right. Thank you. Thank you. So we're excited that finally those got done and the systems issues were resolved. So you should be seeing payments on those very soon if you haven't already. And then I wanted to address a couple of the pre-submitted questions as well so that we make sure that we get those. One of them was specific to Noridian, asking when we were planning to announce the HCPCS that would be included in our post-payment audits. And I do want to make sure that you are all aware that Noridian has announced those codes. They are L codes at this time, L 1833 and 1851, along with two A codes, A 4352 and A 4353. Both of those are urinary catheters. So just a little update on that. You can find that on the Noridian website as well under the medical review tab that you see across the top of the screen when you're on our website. The other thing I would note, the same as Judy was indicating, that we too have very prominently displayed information on COVID-19. Ours happens to be a banner across the page, but it's a matter of clicking on that banner to be redirected to all things related to the COVID-19 public health emergency. And then I thought I would just go through these questions because I had initially looked at them, and then Judy confirmed that we're on the same page. And then we'll go back to some of the questions that are being typed in. So the first one was, can the MACs provide an ETA for when the additional CARES Act funds will be paid out? Yay, we did that. It's all done. So hopefully, as I said, you'll be receiving those monies very soon. There could be some other editing issues that would trip up, a few of them in like normal claims processing, but nonetheless, the mass adjustment has been completed. And then I believe that Judy addressed this as well. Have the DME MACs addressed the beneficiary signature issue with CMS, which allows for POD to have documented without a live signature, but doesn't allow the documented signature for ABN. I want to just confirm that there are guidelines that do allow for an ABN without the signature. And that's true even in a non-public health emergency. But the ABN can be issued, making sure that if someone has to take it into a hospital room, that there's information, call information, so that the beneficiary could ask questions if they needed to, and that type of thing. What there isn't is the allowance for the assignment of benefits or the beneficiary authorization to be completed. And as Judy mentioned earlier, and I think it was in the presentation as well, we are seeking additional clarification from CMS, but we do not have that at this time. Then they're moved on to an oxygen specific. When a patient is ordered oxygen during a physician office visit, if they are started on the prednisone taper, does that remove them from the chronic stable state? Well, possibly. I'm not sure that we could fully answer this question because it does depend on the totality of the medical record. We can't, obviously, Judy and I can never pre-approve claims, but what we do say about physicians' visits that are different than hospital stays is that a practitioner has to, if in an outpatient setting, the beneficiary has to be in their chronic stable state. So depending on what else is in the record that warranted that prednisone taper could disqualify them, because it's all about the way it's displayed in the medical record. And so we apologize, we can't be more definitive than that, but without actually seeing records, it would be a disservice for us to comment. The next one was when a beneficiary received a CPAP from a different company and same and similar is checked, and there's determination that Medicare has paid 5 of 13 months, what documentation needs to be provided for the supplies for the patient. In order for you to resume billing of the rental, of course, all qualifying documentation would have to be met. So you would have to know that they were compliant in their trial period and that there was a continuing need and that they were practicing that need. The only exception to the original face-to-face document and the sleep study occurs when Medicare has paid the full 13 months. So we just wanted to make sure that that was clear. If Medicare paid the full 13 months, then you would not be responsible to have the original face-to-face document and the original sleep study, because qualification would have been established at the time Medicare paid for the device. But if Medicare has only paid partial months, you would be responsible in a review situation to be able to produce those documents. The next question was, what documentation is acceptable when you have a patient who has a sleep study in December of 2019, for example, and chooses to postpone therapy? Then they request the therapy to start 10 months later. Do you need a new face-to-face and detailed written order? So Medicare does ask that therapy begin within a reasonable time frame. Generally, we define that as 3 months. However, the testing can be no greater than 12 months. So in this case, a 10-month delay wouldn't necessarily disqualify them, as long as there was the face-to-face prior to the sleep study and then the qualifying study and therapy was initiated within 12 months. Again, we prefer to see a shorter period of time, but in no case longer than 12 months. Then this is a great question, and it's actually been sort of talked about fairly frequently in the last couple of years. What time frame can testing be when a patient is released from a skilled nursing facility? And we're assuming that you're asking for oxygen. I know that's a dangerous word, but nursing facility testing is considered to be in the chronic stable state. So within 30 days of an initial CMN, if the patient is in a skilled nursing facility. The only time that you get the within 2 days is from a inpatient hospital stay, and that is not what we consider the nursing facility to be for the purposes of testing. And then here's a fairly lengthy scenario. The beneficiary had a CPAP set up on March 1st of 2020, which could be a significant date, obviously, as that's the date the PHE started. And this beneficiary has not yet had the required 60 to 90 day face-to-face. The patient is compliant for usage, and they have used the CR modifier for June and July. We have asked the beneficiary to get a telehealth visit with their doctor, but they haven't. Can we continue to bill the CPAP with the CR modifier as long as the patient is compliant and the beneficiary indicates that they do not want to make a doctor's visit? So the billing of the month 4 and beyond does require a face-to-face visit. The waivers and flexibility have only changed to allow that face-to-face visit to be completed via telemedicine. It doesn't allow a waiver of the face-to-face altogether. So there would have to be communication between the beneficiary and their doctor before the supplier is allowed to bill that month 4. And then the final question that was pre-submitted is, we have patients with commercial insurance and Part A Medicare only. 5 months into the rental, they become Medicare Part B eligible with Part B primary. Is it correct that having Part A only is not taken into consideration, and that the patient would need a new face-to-face and need delivery paperwork after Part B eligibility? Pardon me. And the answer to that is yes, because Part A and Part B are totally separate. Part A is an entitlement, Part B requires enrollment and premium payment. Part B is the umbrella under which DMEPOS is covered. So once a beneficiary has Part B, then all of the requirements for Medicare under Part B must be followed. Do keep in mind that there are policies like PAP, for example, that we've been talking about, have specific guidance for beneficiaries entering Medicare Part B when they're already on therapy, and there is a section in the LCD about beneficiaries entering Medicare. Proof of delivery is still going to be required for all new Medicare Part B DMEPOS beneficiaries. So we hope, I hope, but Judy and I looked at these together, as I said, that helps with those pre-submitted ones. And now, so that you get some variety, I'm going to turn it back to Judy to take a look at some more of the questions that have been coming in during the presentation. Judy?
Excellent. Thank you so much, Cindy. And we are getting a myriad of questions in all types of topics. So one of the questions is, what is the status for the 2021 competitive bid announcements of bid winners and implementation? We have not received information yet as to who the contract suppliers will be or anything on implementation. I strongly suggest that you refer to the CBIC Competitive Bidding Implementation Contractor website for the most current information. An issue about that, a question about the CO 151 denials that were denied incorrectly through jurisdiction B and C. Does that specifically reflect an A7046 as a 6-month replacement? There were numerous HCPCS codes and claims affected. I cannot tell you if that specific claim was affected by this particular issue. What I can tell you is the issue has been resolved and claims are being corrected as quickly as possible. If the claim was processed and denied prior to September 22nd of this year, then it was not affected by the CO 151 claims processing issue. Can you check cert status through the portal? And you cannot check it through the MyCGS portal. However, we do have a cert claim identifier tool that's available on our website for your assistance. And you just enter your CID, and that will assist in providing the status of that particular cert request. Cindy, what is your process for cert requests and checking status?
Thank you, Judy. And Noridian has a similar location where you can enter the CID on our website and get some information in the portal, as well as, and there is a new, and we will be advertising this. We just talked about it yesterday at the DME CERT Task Force meeting. CERT has a new email address that will allow suppliers to contact CERT. So look for that to be posted to the CGS and the Noridian websites, as well as some notifications via email to various associations, including all of those participating in this wonderful event that has been hosted by MAMES. So, you know, and again, I would like to say, certainly on behalf of Judy and myself, thank you for inviting us and allow us to participate. When you record a session, it's sometimes you forget the normal housekeeping stuff that you do when you are there in person. So we are very pleased that we've had the opportunity to bring information to all of the associations that are participating in this MAMES event. So Judy, back to you.
Okay, great.
Let me know whenever you want me to take, let me know whenever you want me to take any questions. So.
Excellent. Thank you so much. And again, I'd like to reiterate what Cindy had stated. Thank you all so much for attending today. We do greatly appreciate your support, as well as all of the wonderful questions that you are asking. We really appreciate the support that we receive from our associations and to be able to be here today. So thank you again. Okay, let's see. I did see a question. Someone had moved into chat for a pending question in the Q&A panel. And we are still working through the questions. I'm not sure if you can see all of the open questions, but we are currently trying to answer those as quickly as possible. We get differing information on delivery dates. We've been told the ship date can be the data service or actual delivery date. Also, we've been told the ship date, we can ship up to 10 days in advance for the 90-day requirement. Which is correct information for the shipping of supplies? Well, I think the issue is that you're talking about two different points, okay? So if you are utilizing method 2, proof of delivery, which is when you're shipping the items to the beneficiary utilizing a shipping service, you can use either the data service, the delivery date, the date that the shipping services information was created. As long as there's not too much difference between those dates, you do have some flexibility on your dates of service for shipping. Okay, the second issue that you're talking about is actually request for refill. And that request for refill that you can ship 10 days in advance, that really has to do with the beneficiary exhausting their supply. And because you're referring to PAP supplies, there's not really an exhaustion issue. Medicare will allow for replacement PAP accessories if the beneficiary, the items are no longer functioning. So for request for refill for those items, we would be looking for documentation of the functional condition of the item that is being replaced. So again, I would suggest taking a look at request for refill in addition to proof of delivery. So I think there's a little bit of confusion there. But it's a great question. Okay, let's see what else we have.
Judy, this is Cindy. Can I just reiterate, we have one longer question about beneficiaries coming to traditional fee-for-service without access to the sleep study. And as I indicated before, if Medicare paid for the device, then the coverage criteria is considered to be established. But if Medicare didn't pay for the device initially, and they're now coming to Medicare fee-for-service, there is a requirement for a sleep study that meets the coverage criteria in effect at the time they enter Medicare. If that can't be located, then to continue on PAP service for Medicare purposes, it may be a requirement that that beneficiary would have to have a new diagnostic study, because they do have to show that they meet the diagnostic coverage criteria for Medicare purposes. So thanks, just wanted to interject that.
Excellent. Thank you so much, Cindy. Let's see what else we have. Does a standalone home infusion therapy follow the same brick and mortar that a regular DME must follow? Well, the medical policies would be the same. However, regarding the supplier standards and the statutory requirements, that would be a question for the National Supplier Clearinghouse. We recently received several hundred denials for March and April dates of service, including claims adjusting and JB requests and refunds. A phone call stated those were issued in error. So instead of paying an additional amount for the CARES Act, they were requesting we refund the original payment within 30 days. And again, this is that issue that we have posted on our claims alert page. And I'm assuming those claims did process in those dates of service, those processing dates that I mentioned earlier, through the 23rd and 24th. Either they were in process or received on that date. So please just be patient. We are resolving those claims as quickly as possible. Okay, Cindy, go ahead. I'm going to turn it over to you for a little bit.
Sure. I will go to some of the open questions, and we'll just see what we can, I'll just start going down the list. I signed my company up for immediate recoupment of overpayments. Where can I find the transactions where this is being recouped? Is there a report I can review? You've lost visibility to what is happening. If you have signed up for immediate recoupment, you should see recoupment happening on your remits in the same way as if you had requested it. If you have specific examples, we would encourage you to contact our call centers and give them the specific example and help to determine what has occurred on that specific claim. Because, as I said, you should see those recoupments occur on remits the same way as if you had sent in the request rather than, having it be already in place. The next question is we get, Judy covered the delivery dates. It's interesting, these questions pop around a little bit. We don't know if you can see them or not, but depending upon who's asking the question, it will change the question scenario. So please be patient with us. So I have a question from Barb with the jurisdiction DDAC. I have a number of calls regarding my comments about being mine about the AOB. And we knew this would be an issue needing to be signed. A number of suppliers have their AOB printed on the delivery ticket, and we understand that, and that is the exact question that the DME MACs have submitted to CMS. So the question here is, if the delivery ticket requirements were waived during the PHE, they wouldn't have an AOB on file. What do we advise them to do while this is being looked at? You can't unring the past, but we would advise making sure that you get assigned AOB for any services that are beginning now. And if you have beneficiaries on service, it's a business practice to determine whether you want to get some sort of assigned document from those beneficiaries prior to submitting your next claim, or to wait until we get clarification. But we can tell you that CMS has at this time guided the DME MACs that we are to be educating that there needs to be a signature and an authorization in order to build a Medicare program. So I guess from my perspective, I won't speak for Judy on this particular topic, but from my perspective, it would behoove you to begin looking at how to obtain those signatures for ongoing rentals. If they were sale or a patient is already off service for something related to earlier in the pandemic, we'll just have to wait until we get the guidance from CMS. Great question. All right. Here's one I don't think I've heard vents talked about. If a beneficiary has a ventilator and is on a commercial policy then becomes Medicare effective, does the patient have to have a face-to-face after Medicare effective date, or can the face-to-face be within 6 months of the Medicare effective date? So this is an interesting question because as you all know who provide ventilators, Medicare doesn't have an LCD, there's only the NCD, and the beneficiary has to have one of the, or a diagnosis that fits into the specific NCD category. Beyond that, there is no other guidance. So at that point, you would refer to the standard documentation language, which does indicate that ongoing medical need has to be shown within 12 months of any date of service. So they, as a beneficiary came into Medicare, it would be necessary to show that they were using, benefiting, medical need. You'd have to have a standard written order. You would have to have proof of delivery, all of those types of things, but there would not be a specific requirement for a face-to-face. Good question. You guys are very busy with good questions today. We did the delivery dates. Talked a little bit about CPAP or BiPAP. Oh, here's a good one on an OMP item. We received a RAC audit on a cock-up wrist splint. The patient had one 3 years ago. RAC cited the 5-year RUL. Would having a current RX plus DWO be enough, or is there special language in the doctor's chart notes needed? Well, first of all, as you know, we can't make advisement on what should be in the clinical documentation. We want individual beneficiaries evaluated and have it detailed in their clinical record. The RAC does have a, I believe it's a 3-year look back period. So it is possible, certainly, that they would be recouping for another splint provided within the 5-year RUL. However, it's also possible it's a different event. So again, you would look to the detail in the medical record to make the determination on whether or not it really should have been provided as a new item within that previous 3-year RUL.
Cindy, may I add to that one, please?
You betcha.
Oh, thank you so much. So the DME Max did publish an article, it was back in August, regarding same and similar items and the appeals process, I believe that, or same and similar orthotics and the appeals process, and that is the exact title, I believe. Jurisdiction B and C has also published a checklist for replacement orthotics. We have seen quite a few orthotics, whether it's through RAC audits or claims that are on initial submission, denying as same and similar due to the beneficiary having a previous item. An example would be the beneficiary initially had a walking boot, and then for some reason there was a change in condition, a change in the physiological condition of the beneficiary within the reasonable useful lifetime, and the beneficiary now needs, say, a custom fitted AFO. So in that scenario, we would expect to see documentation to substantiate the change in condition that necessitates the replacement item, as well as documentation as to why the previous orthotic would not suffice. So when you are requesting a redetermination on those claims, please be sure that the documentation in the medical record substantiates the need for the new item, substantiates why a replacement is being provided, and that the previous item would not suffice for that beneficiary. Thank you, Cindy.
Great, Judy, thank you very much. Okay, have you, yes, we too are aware that there are significant concerns about the same and similar, so that's a great one. I'm sorry, I keep trying to fiddle with my camera here. Let's see, there's a follow-up question regarding saline, but I don't think I've seen the original question yet, so let's get back up here. I can answer
that one.
Oh,
Cindy, I answered the initial question.
Okay.
So your solutions that are used to moisten gauze, such as saline, are automatically denied as non-covered if they are provided under the surgical dressing benefit. So you would receive a patient responsibility denial. You do not need to obtain an ABN because you will receive that PR denial. However, if you choose to provide a voluntary ABN, that is absolutely an option. Sorry, Cindy, back to you.
No problem. That's why we're a good tag team. So this is a follow-up question to a CMN question. If we get the qualifying information, so we now want to get a CMN, we're in the 3rd or 4th month of billing, do we get it initial or revised? That's a great question. And that's also a question that I've put on the list to submit to CMS. If you didn't have a CMN initially, even though the beneficiary was on oxygen, it seems logical to me that now that you have qualifying testing, this is the initial CMN with the qualifying information. However, the guidance could be different at some point in time, but like I said, if you didn't have qualifying testing and now there is qualifying testing, you can complete that, or the practitioner can complete the CMN in its entirety. In my mind, that would make it an initial. But we will get more information related to that question because that's another clarification that we have been asking. Keep in mind that the DME MACs have been provided no guidance that we can pass on to you for what will occur when the PHE has ended. And in fact, there's been no announcement of the end to the PHE at this time. But we do recognize in our sharing with CMS that as some areas begin to reopen, there is the ability to get those patients tested, and we absolutely encourage that so that they are meeting the coverage criteria wherever possible. Then there's another question. I missed the response to whether or not competitive bid would be delayed. Unfortunately, that's not a question that we can even address. That's the competitive bid implementation contractor that would take that question. We, however, at this time have no information and have not been informed of any delay of the competitive bid program. So great questions, great questions. If a patient has not met CPAP compliance and is on their 2nd compliance period, whoops, again, the question's moved on me. Hold on.
Sorry,
Cindy. That's all right. It is sort of interesting to have the opportunity to do these virtually because when you're, and it's a different platform than what we generally use for our webinars, so the questions move differently. So here we are. If the patient has not met CPAP compliance and is on their 2nd compliance period, what is needed if the doctor now orders a BiPAP? Well, anytime there's a change in condition, there will have to be a clinical record of why the BiPAP was ordered, what wasn't working with the CPAP, why did the beneficiary move to BiPAP, those kinds of things. And then there's a new trial period on the new device. So again, we can't emphasize enough clinical record of why that beneficiary is moving to a different device. Let's see. Okay, I gave an example of a partially paid PAP rental, 5 of 13 months. If a new supplier takes over for supplies only a year later, will Medicare allow for the supplies if the PAP did not cap? Maybe. That's a great question because it depends on what happened. If the beneficiary, if there's indication in the medical or in the Medicare system that the equipment was picked up, they no longer have it, or if they failed compliance, maybe there was extra billing and then some supplier determined that they really shouldn't have billed those months and a refund was done. It depends on why only 5 months was billed. Now, we may or may not know why, but if we do know, and there's a reason that we would not continue to pay rental, then we would not pay supplies because the beneficiary has to qualify for the base item in any case before we will pay for supplies and accessories. But if there's a situation where we do know, and I gave you a couple of examples, then we might not pay for supplies. So you do need to do your due diligence, not only with the beneficiary, but in checking same and similar and trying to determine or ascertain what had happened with that previous device. And then, of course, beneficiaries have to be needing and continuing to use that base unit in order for us to cover the accessories. Great questions. Here's another one. Being that a patient is not in a chronic stable state when discharged from the ER, would the PHE go into effect because of possible COVID? What do you recommend for those patients that require the oxygen? Well, here again, two different things, and I'm going to talk about it in normal times. Hospital discharges well, if they're in the ER, they haven't been admitted. So ER testing would almost always disqualify under normal times because there's no testing within 2 days of discharge. Because they've never been admitted, they're obviously in an exacerbation or acute state. But for those beneficiaries who are admitted and have their testing for oxygen within 2 days of discharge, again, it's all going to be about what's in the medical record. Are they on the prednisone taper? Are they on antibiotics? Does the medical record indicate that even with those alternative treatments, the beneficiary is still going to need the oxygen? Why? What's in that clinical record that will paint that picture? Is it being prescribed for a reasonable amount of time? You know, all those things factor into a review. Now moving into the PHE, where everything is different and we're not enforcing the clinical criteria under the oxygen policy, the beneficiary does not have to be diagnosed with COVID-19 in order to qualify. If a practitioner prescribes oxygen, as long as there is a medical record detailing why that oxygen is being prescribed, you would need to produce that in the event of an audit, and your claims should all be submitted with the CR modifier and the COVID-19 narrative, and that will continue on each rental month for that beneficiary. So hopefully that helps with that one as well.
Cindy, we have received the 5-minute notice. So I just want to reiterate to everyone, because we're receiving a lot. I'm just
going to take some responsibility there. Sarah can't do math this morning, so we do have until 10:30 this morning. My apologies.
Okay. All right. Well, still, I'll continue on. So some of the questions that we are receiving, CTS as well as Noridian does hold webinars almost on a daily basis. We also have our Ask the Contractor teleconferences specific to PAP, because a lot of the questions we're receiving are PAP questions, oxygen questions. We do have webinars specific to those topics to be able to answer any of those questions that you may have throughout the duration of those presentations. So just a reminder that those resources are available to you. And Cindy, I'll go ahead and take a few questions, give you a minute for a respite.
Perfect.
Should we?
Thank you.
You're welcome. Should we use an ABN, Advanced Beneficiary Notice of Non-Coverage, for upgraded equipment or equipment that is not fully covered, so the patient is responsible for the difference in the cost? Well, I'm going to address the upgraded equipment. I'm not quite sure what you're referring to as not fully covered, but if the beneficiary requests upgraded equipment, if the physician orders upgraded equipment that the beneficiary does not qualify for, I'll use a hospital bed as an example. It's an easy example. So the physician orders a fully electric hospital bed, the E0265. Medicare never covers a fully electric hospital bed, but the beneficiary does qualify for the semi-electric, the E0260. In that scenario, absolutely, in any scenario like that. So the beneficiary is qualifying for a K1 manual wheelchair, but you only have a K3. Now, in that scenario, you cannot bill the beneficiary, since that's a supplier-provided upgrade free of charge. But if it's a beneficiary-requested upgrade, a physician-ordered upgrade, you can absolutely provide an advanced beneficiary notice of non-coverage. Medicare will allow the lower-grade equipment that the beneficiary qualifies for, And then the difference would be patient responsibility, or PR. So the beneficiary would be responsible for the remaining balance. So that's a great question. Lots of great questions today. Let's see what else we have. There was another one I wanted to share with everyone. Just one moment. I apologize. Oh, another question was regarding the reasonable useful lifetime. So the reasonable useful lifetime for the majority of base items as well as orthotics is 5 years. And I know that some items, suppliers really do not feel that some items will last for the full 5 years. Unless it is specified in a particular medical policy or policy article, a different reasonable useful lifetime, the reasonable useful lifetime is 5 years. Medicare will not pay for a replacement of DME or orthotics due to wear and tear. Okay, we will consider replacement if there's a specific incident that happens. The item is lost, stolen, or irreparably damaged due to a hurricane, flood, fire, something like that. If there's a change in the physiological condition of the beneficiary that necessitates a replacement or a different item, in those scenarios, we will allow for replacement within the reasonable useful lifetime. And I'm assuming most of you probably don't provide lower limb prosthetics, but those rules do not apply to lower limb prosthetics due to BIPA of 2000. They have some different replacement guidelines. Okay. Let's see what else we have. Cindy, is there anything you would like to answer at this point?
No, I don't think. I see. Oh, here's another good, and I think Judy makes a really good point that we do regularly have webinars that we certainly would encourage you and or your staff to attend. And many of these questions come up in these webinars, so we're glad to see them here too and be able to provide those responses. And additionally, for Noridian, we do have some online tutorials addressing many of the policies, as well as both CGS and Noridian participate in collaboration with the Part A and Part B MACs. And there are a number of tutorials that are available on our website and on the AB MAC websites that are joint information regarding what is needed from the practitioner community for the prescription of DemiPost items. So you might want to look for those too. They're now housed on a YouTube platform, so they may be more accessible to you. But this question is about beneficiaries who move outside of the service area of the current oxygen supplier. And the question is, can a new capped rental period begin with the new supplier? And if so, do we need a new CMN, new testing, new order? How do we bill for this? Well, it's all going to depend on what has happened. But generally speaking, if a beneficiary moves out of your service area, you don't have to assume service. If you do assume service during the rental period, then you would only receive the rental months that remained in the rental period. You would have to get the appropriate CMN if you can't obtain a copy from the previous supplier. And there has to be ongoing medical need. Now, if that oxygen beneficiary is in months 37 through 60, it is the obligation of the supplier who receives payment for months 36 to continue providing that service for months 37 through 60. So in that case, if you were assuming that service, then you could subcontract with that previous, with the initial supplier to continue providing that service for them if the beneficiary moves outside of their service area. But it's two different situations, because if they move outside in the rental month, we ask suppliers to help beneficiaries find a new supplier. If they move outside the rental or the service area in months 30 through 7 through 60, it is still the original supplier's obligation to make sure that oxygen is provided. And again, the certifications will depend upon whether or not you have access to the certification that the previous supplier possesses. There's a follow-up to the question on PAP compliance and whether or not the clinical record is a new office visit or a new titration study. So I'm thinking we're going to, if they become compliant in the during the second trial, and really once that beneficiary meets the compliance requirements of greater than or equal to 4 hours per night in 21 days in a 30-day consecutive time frame, as long as that's communicated and they do have face-to-face with their practitioner, then that can be billed immediately. The 4th month can be billed. So it's just required that that be recorded. Sorry, lost my train of thought. For those of you who don't know, I'm on the West Coast, so it's still relatively early here. We started pretty early. So Judy, I'll see what you've got right now, and I'll continue to scroll through here.
Looks like we only have a few more questions to address. So in addition to, I know we're getting a lot of questions, and Cindy had addressed the post-pay audits that are currently occurring, as well as CERT and recovery auditor audits, a lot of which have started back up. So if nothing else, if I can really express the benefits of utilizing our documentation checklists, Noridian has documentation checklists, as does CGS. Prior to responding, or perhaps even earlier in your process if you want to do an internal audit of Medicare documentation. But most importantly, prior to responding to those audit or review requests, grab one of those checklists, if there is one applicable to the item that you're receiving the request for, and go through your documentation to confirm that your detailed written order or standard written order dispensing orders meet Medicare requirements, that you have all elements of your proof of delivery documentation, and that your medical records are signed, that signatures on medical records as well as orders are legible. If the signatures aren't legible on medical records, you can obtain those attestation statements or signature logs. If signatures are missing from the medical records, confirm that you can also get those signature attestation statements. They're not good for orders, but you can absolutely get those for medical records that are missing signatures. They are some of the top issues that we see. So we would like for suppliers to never have any of those little technical components of documentation type denials. So again, if I can scream the benefits of utilizing the standard documentation requirements for all claims policy article, as well as our documentation checklists, just to avoid any of those denials. And it looks like a few more questions have come in while I was on my rant. Let's see what we have. Looks like we're waiting for a question on complex rehab. If the base has reached its reasonable useful lifetime and be replaced, do the accessories for the new chairs also need to reach RUL, or will an ABN be need to be obtained for those accessories? So if those accessories cannot be utilized on the new chair and the beneficiary is receiving a new chair, Medicare would consider the replacement accessories on the new chair. The documentation would need to substantiate, again, if there's a change in the beneficiary's condition where they're changing groups of chairs. So under most circumstances, if that base is replaced, those accessories would be allowed as well. Cindy, did you have anything you wanted to address?
No, it looks like we're sort of getting to the end of our questions. I was going to look in the chat and make sure that we had gone over everything that's in the chat. Some of the questions are the same in chat as in the Q&A, so we're doing our best to make sure that we get to everyone. I don't know if we talked about this, but I guess sometimes it bears repeating too, because sometimes we're all trying to multitask or whatever and may miss something. So this one on, can we address billing transition patients for suppliers who are going out of business, specifically PAP? Would the new supplier resume billing rental months or start a new capped rental? Well, obviously it's going to depend on where that patient is. I mean, if they're at the end of their 5-year RUL, then certainly you would take over. But if they're still in the 5-year RUL, then that's simply a matter of a beneficiary-owned PAP, and assuming that the full 13 months has been paid, and as long as that's the case, then the supplies will be covered regardless of whether or not the previous supplier went out of business. Now, depending upon where they are in the rental months, if they're still in the capped rental period, you certainly can take over that capped rental period. You would not get to start a new capped rental period, and you would also want to be very careful about making sure that all of the compliance requirements have been met, because as you take on a rental and supplies, you want to make sure that you're protected by the fact that you have access to the original face-to-face, the qualifying sleep study, and the evidence of ongoing medical need. So treat those beneficiaries as you would those coming on service for you. The fact that the previous supplier has gone out of business won't change the requirements for you to have to make sure that you have all the qualifying documentation. There is one place in the oxygen arena where, for those oxygen patients who are abandoned by suppliers, meaning that they just disappeared, not that they went out of business or that they closed a branch, but they just disappeared, then there is an allowance for a supplier taking over to get a minimum of 10 months of rental in those cases. You all are asking great questions today. Very, very busy. We did have one question. Sometimes if you're asking a question about or making a statement that you have already called our contact centers and you're having trouble with getting the assistance that you need, the education department doesn't do claim-specific issues, but we do obviously clarification on generalized topics. At Noridian, we use our DME webinars email address to allow for those general questions. Please don't email us any PHI. And then we assign those to subject matter experts, and that's DMEwebinars@noridian.com. And I know at CGS you have community coaches, so I'll let Judy talk about access to community coaches.
Thank you, Cindy. So every state in both of our jurisdictions, or numerous states, do all have individual community coaches to assist with any educational requests, complex type inquiries. We don't usually answer claim-specific issues, but we do have an email address that is available on our community coach webpage for jurisdiction B and C, and that is under education in the left-hand navigation of the CGS webinar. I'm sorry, website. So you can absolutely go to our website and obtain that email address. And Cindy, you're being requested for your email address, or for the group email address.
Alrighty.
For questions.
Our groupie, yeah, I was going to say, there's probably enough people who have my email address already, and which makes me slower to answer. But I'm going to give the DME email address, and that's DME webinars, WBINARS, @noridianmedicare.com. And that's a general email box where You can send us scenarios that you would like to see in our Level 200 webinars. You can send questions regarding a specific webinar. You can send general questions asking for additional information on policy requirements. What we won't do is claim specifics, because that's what the contact center needs to do for you. To be honest with you, we don't even have access to be able to dig into the claim specifics. And please don't include any PHI in an email.
Ever.
Ever. And yeah.
Okay, looks like we're just about to wrap it up. I did see one additional question come in regarding orthotics that are custom fitted. What documentation is required for the fitting and adjustment? We would be looking for documentation from the orthotist of exactly what was done to that item to create a custom fit for the beneficiary. So we'd be looking for any heat molding, bending, anything beyond off-the-shelf strap tightening type of information. We'd be looking for very specific information as to what the orthotist did to create that custom fit for that beneficiary. And I think we are out of time.
Wow, that was absolutely awesome.
Oh my gosh.
Wonderful job. With that, I want to transfer it over to a special thank you for both of you, Cindy and Judy. Thank you for being here. So I will have Sarah take that away. Wow, thank you so much to our presenters, Cindy White and Judy Roan. The updates we need surrounding the Medicare DME MAC jurisdictions A, B, C, and D. We appreciate your expertise and time putting together that excellent presentation. And with that, my friends, we are on to our final break of the MAMES 2020 Connecting the Space Between Us event. So please, take a few moments to refill that coffee, tea, or water, stretch those legs, and get ready for some fun with our final session and keynote speaker, Michael Kerr. You're all pros by now, but remember to click the Attend Webcast button as soon as it pops up, as you will not want to miss a moment. And before we get to our closing keynote speaker, I wanted to bring someone on to help us thank Rose and Jim for the incredible work they've done to help us keep this conference alive and well.
Hello, everyone. My name is Mary, and I'm Rose and Jim's youngest daughter. In 1999, Sarah and I watched our mom embark on a new journey with building her own business. With it came this association called MAMES. We saw the office setup get bigger and bigger in the basement. We waited to make phone calls and use the internet for 3 to 6 hours as the newsletter was sent on Sunday nights. We worked our first jobs as packet stuffers for the conference. I then went and put on my first protest for fair wages when I found out Sarah was making more money than me. We went on road trips to conferences of years past and have watched this conference grow and innovate every single year.
In 2005, Dad decided to join Mom on this journey, and here we are 15 amazing years later, watching them grow and lead together. Watching them work together has been truly a work of art. Kids these days would call them hashtag a power couple or hashtag couple goals. To us, they're our amazing parents. They taught us the value of hard work, sticking together, sticking up for yourself, and most importantly, that I love you, but I just don't like you very much right now principle that comes with working with a family.
To all of you, we have loved growing up watching members of this industry come together every year with such a desire to learn. For those of you that have been with us for a long time or since the beginning, thank you for your continued support. And for those of you that are new this year and joining us from associations around the country, we hope you've seen the value in the incredible events such as this. Mom and Dad, I know I wouldn't be here without you where I am today.
Nor would I, Mary. Thanks for sharing that. So as we wrap this up and get excited for our final keynote speaker of the conference, I just want to say thank you again for joining us. Together today, we can quite literally say that all of these people here wouldn't be here without Rose and Jim today. So thanks, Mom and Dad. Thanks Thank you for your creativity and bringing us together in a time when we as humans and the industry need it most. The industry is lucky to have two people who care as much to see it not just exist, but to thrive. To everyone out there, thank you again and enjoy our closing keynote speaker, Michael Kerr, in just a few moments.